So we'll start the meeting for today. And this is just a word of welcome for a couple of minutes. I would like to welcome everybody to this final days program on November 14th. And we have a very, very interesting array of speakers lined up for you in the next 60 to 90 minutes. I would like to first of all thank all our board members. We have Dr. Abbas from Tanzania. We have Hari Krishnan Iyer from Malaysia, Mariam Botros from Canada, Hermelinda Pedrosa from Brazil, and Nicholas Papinis from Greece. And we have a whole lot of regional council members from 7 regions of the world. We would like to thank our sponsors, Urgo Medical, Molinic Healthcare, and also Advanced Medical Solutions. The participating organizations are Pan-Africa Diabetic Foot Research India, Asia Pacific Association for Diabetic Foot Problems, Wound Canada, Canadian Podiatric Medical Association, and the World Union of Wound Healing Societies, and Diabetic Foot Research India. DFoot, as you all know, is a registered international non-profit association under Belgium law, and it consists of 7 regions in the world. We have regions from North America and Caribbean. We have the region from Europe. We have SACA, South America and Central America. We have Southeast Asia, we have the Western Pacific. We have the MENA region, Middle East and North Africa, and Sub-Saharan Africa. So this is, I'll be talking more about it a little later during the panel discussion. So the DFoot and IWGDF are 2 organizations like brothers and sisters to each other. And we have Professor Nicholas Schapper, who represents the IWGDF. Last year, we started this flagship project of DFoot, which was the Diabetic Foot Awareness Week from the 7th to 14th. And this year, we had a repeat of the same activity which we did last year. We had the 7 regions completing their region till yesterday. We had started with Sub-Saharan Africa. On the left-hand side, you see Abbas. Then we had the SACA region, which you see in the center. Then we had the NAC region, which you can see here, which is the pointer. And then we had the MENA region, down you can see down. And then we had Europe. And then we had the Southwestern Pacific region. We had the NAC also. And then finally, yesterday we had the Southeast Asian region, where we had India, Bangladesh, and Sri Lanka. So that completed all the 7 regions till yesterday. And we have today the grand finale, where we have a galaxy of speakers who will be giving their talks. The first talk, without much ado, without wasting much time, I'd go to the first speaker. It's a great honor to introduce Professor Nicholas Schapper from Netherlands. Yeah, so Professor Nicholas Schapper is the chair of the IWGDF guidance, and he's also the chair of the ISDF. As I told you, there are 3 organizations, the implementation arm, the guidance arm, and the Congress. And Nicholas Schapper, Professor Nicholas Schapper is in the chair of the IWGDF guidance and the chair of the ISDF. And the IWGDF guidance is written once in 4 years and presented at the ISDF. Many of you must have attended the meeting in Hague, Netherlands in 2019. And we eagerly look forward to the 2023 meeting, which Professor Schapper will be arranging for us. So with this, I would request Professor Nicholas Schapper to share his slides and start.
Thank you very much, Vijay. Thank you very much for your kind words, and very much also thank you for giving the opportunity to be here with you, with Deformities, which, like Vijay said, is now clearly a partner organization of the International Working Group, the Diabetic Foot. So we always enjoy being with you and sharing ideas and thinking about the future also. For that reason, I was asked to give you a brief introduction today into the work of the International Working Group. I do apologize that for many of you, this will be, I think, old news. In particular because several people of your board have also been involved in translating our guidelines, so they know everything from A to Z. But maybe others not. So that's why Vijay asked me to give you an overview of what we've been doing. We are an international registered organization. We work together with the IDF. We have a collaboration with the IDF. We all know that the IDF has been in trouble, but 1.5 years ago, we renewed our very close collaboration with the IDF. We also work together with the American Association for Infectious Disease and the American Vascular Society. They are nowadays involved in developing our new guidelines. And of course, we are, and I will come back to that, closely involved with Deformities also. But the first question is, of course, why? Why guidelines on diabetic foot disease? Well, one of the reasons is that there has been a rapid increase in knowledge in many related fields that are relevant for the diabetic foot, for the treatment and prevention of diabetic foot ulcers and other complications. So if you simply type in, like I did, in PubMed diabetic foot, you come up with 30 publications in 1980, and most of them are anecdotal or reviews. Nearly none of them are clearly what we would call now scientific studies. And that has dramatically been risen up to more than 1,400 in 2020. And of these 1,400, of course, again, many of them are just simply case series or are reviews or are systematic reviews. We have maybe too many of them, but still the number of good quality clinical trials has clearly increased in the last 15, 20 years. So the knowledge base is increasing. And all that knowledge has to be synthesized by the clinician who sees and treats the patient and by the team he's collaborating with him. So we need a place where we can find all this information together and where it is translated for us. At the end of the day, I'm also a clinician like you, in what do I have to do in daily practice? And that is what we strive to do. And that's why we develop guidelines. But, and that will be a theme repeatedly in my talk, but to do so and to be accepted all over the world and to enable implementation, that process has to be completely transparent, and that process has to be as much as possible based on current evidence, evidence-based guidelines. And that's not an easy process. And that's what I will share with you, how we do that. Because some people of Deformities, I know that, we have been discussing with them, they say, well, and I think their criticism is correct, say, okay, you have these beautiful guidelines, but you know, I'm there in South America, in Chile, most of the time it snows and people are 500 kilometers away from the hospital. What can I do with a guideline that says blah, blah, blah? Or people from Bangladesh will say, okay, you say that a non-removable cast, a non-removable knee-high cast is the gold standard for treatment of a plantar foot ulcer, but our country, at least in certain regions, is 30% of the time flooded. And in those situations, a plaster is clearly contraindicated. So, yes, but the idea is that you can read in our guidelines why we've picked these studies as being the fundamental ones on which we build our evidence. So if there are aspects missing about applicability, please try to solve those problems in your context. And with that, I will also end my talk. So for conditions for successful management and prevention of patients with a diabetic foot ulcer, you need to have, as I said, common knowledge base. Also important is you have to have a common language. When we started, we realized that people use all different kinds of terms and words for maybe the same things, but sometimes they use the same word and we're meaning completely different things. So one of our products, and that's also updated each 4 years, is a set of criteria, definitions, so we all know what a minor amputation is. Because otherwise, if people report minor amputations differently in the literature, you can never compare these studies. You have to have, as a team, a shared sense of urgency. That's why you had this fantastic week about organized by Deformities, because we have to teach each other's, and we have to teach in particular our colleagues, that this is a major problem that needs to be addressed. That's one. And two, within your team, you have to have the shared aims. If you have an interventional radiologist, for instance, I'm just making an example, who is very well trained in opening up vessels, and he just, opens up 2 or 3 occlusions in the lower leg in a patient with diabetes, and then says, well, that's very successful. Yes, that's very successful. But the aim was to increase perfusion in the ulcer and to heal the ulcer. So you have to discuss with each other, okay, if that's your aim, it might be that the way you treat these patients might differ. Because you don't have simply to open up the vessels, but after your procedure, you have to do an angiogram and to see if there's truly perfusion of the ulcerated area. And after the intervention, you have to measure if your procedure was successful. So it means aims. And sometimes for a vascular surgeon, another aspect is that he tries to save as much as possible of the leg. And maybe we as clinicians say, no, maybe that's not the best thing to do, because we strive to have mobility. We want to have a patient walking as soon as possible. So that's things you have to, each of you has to discuss with your team. What are our aims? What are we striving for? And to enable that discussion to become fruitful, you need a systematic approach. And nowadays, there's so much more evidence that we can truly step away from an anecdotal or personal approach, but we can use the literature to translate that in systematic treatment. And due to time, I cannot go into that, but for that I refer to you to our guidelines. And finally, of course, it's all about a multifactorial team approach in diagnosis, treatment, and of course, prevention. But one of the new messages we stress, and David Armstrong, of course, is one of the people who formulated it like this: treat not the hole in the patient, but treat the whole patient. Because the chance of amputation, and that's one of your goals of DFOOT, reducing the number of avoidable amputations, the chance of amputations within the next 5 years in a high-risk patient is 20 times lower than the chance of dying. Because these patients are elderly, these are frail, they have multiple comorbidities, so we should not only treat the whole of the patient, but we should treat the whole patient. And that's again where you need the team for. Otherwise, you end up in situations like this. Everything is fine, it's beautiful, everybody has all the instruments, but we are not on the same track. So how did it all start? Well, it started in 1996 when a bunch of experts on the initiative of Karel Bakker and myself, we met and we start formulating guidelines. And we did that truly expert-based opinion, because here you see in these slides the expert of those days. I was simply the secretary, but of course there's Andrew Boulton, Jan Appelquist, and others who have been so very important in those days in developing the field. And then we sat together here, for instance, in a cellar of a hotel, and we went through the literature and said, okay, this is what we think that should be done. And then the team looked at it and criticized upon it. And then we produced the guidelines. And each 4 years, we repeated this process, And with each 4 years, we try to improve our methodology. And we try to improve the possibilities of implementation. And here you see examples of what we've been doing. And now the 2019 guideline has been published, and we are already starting now with the 2023 project. These guidelines have been published and can be found on our website. There is also a link to our website on the Deform website, but you can also refer them in Diabetes Metabolism Research and Reviews, because that's an open source, open access publication of all our guidelines. And of course, that was not possible without the sponsors shown here. We are an independent organization. We try to represent everybody involved in a diabetic foot. So we have no preferences, but of course we cannot exist without the help and financial support of these people who have no influence at all at our agenda or what we state in our guidelines. So for instance, the 2019 guidelines, it consists of 6 different chapters and a set of addenda to maybe to formulate like that. Everything is combined in what we call the practical guidelines. That's a brief document of 10 pages, but below it, and I always suggest to go there, you find on prevention, the prevention guidelines. There you find the background and the clear recommendations, what we did. The same for the offloading guidelines, peripheral arterial disease, infection, wound healing, and of course, how to approach the patient, classification guidelines, and then how did we do it, development and methodology. And that's what I will go into a bit more detail in this talk. But if you address each of these topics, you're already starting to do a systematic approach. Do I have to offload the ulcer? Is there peripheral arterial disease? And yes, is it so severe that it needs to be treated? Is there infection? And how can I diagnose this? Does it need to be treated and how, etc., etc. This is all based upon a set of definitions and criteria in a chapter and 10 systematic reviews, 10 systematic reviews. It's guided by 6 board members. Here you see the 2019 board members. We have now a new board with Fran Game, for instance, in it. And she is, of course, a very good connection with Deform. And here you see the 6 working groups with the 49 members. We have now an additional working group on charcoal. And we have 50 experts. I will come into that, what their role is, from 40 countries, from 5 continents, for 5 continents. So we strive to be truly a worldwide initiative. It all starts formulating in clinical questions, and that many of you probably have been approached now in the last few weeks, because we are doing this again at this moment. So we formulate the clinical question because the question you asked determines the answer you get. So, and that's where we need the input of the external experts. Do we miss important aspects? And that is reviewed by external experts and the editorial board. External experts who are from Deform, but also who are from the different vascular societies, from the IDF, etc., the organizations I just mentioned. And then once you have your question and you know what topic you have to study, you formulate which outcomes you want. Is it just ulcer healing? Or is it reduction in wound size? Or is it mobility? And then you rate them as critically important, important, or not important. And that will determine your literature search. For instance, critically important, you can read here, incidence, healing, amputation. And then you do a systematic review based on the PICO format, patient, intervention, comparison, and outcome, because you just formulated all these different aspects. And you put that into your PubMed search or the other search engines you use. Usually we use PubMed, but there are also alternatives we use because we try to catch all the relevant literature. And then you perform the systematic review according to the Prisma methods. 10 reviews, now it will be more because we also have charcoal. And then based on the systematic reviews, you enter the next phase and we start formulating recommendations. And that's based on the quality of the evidence, the balance between benefits and harms, patient values and preferences, and resource utilization. And there we call them strong or weak recommendations based on this evaluation. And the quality of the evidence is also rated as high, moderate, or low. Risk of bias of these studies, effect size, expert opinion, because we think that there was something strange going on in the control group, for instance, inconsistency and directness, that's called technical terms, but still we try to approach all these elements. So at the end, we come up with a recommendation. For instance, in a person with diabetes and a foot ulcer, use the SYMBAT system for communication among health professionals about the characteristics of the ulcer. The recommendation is strong, so we strongly advocate it, but actually the evidence is moderate. And you can use these recommendations, there are a bit more than 100 of them, also as quality measures for your own team. Are we using the SYMBAT system? You could ask. And this is all summarized in this slide. You can find that also in our publication. It's up in the upper part, you see the formulation of the literature search and how we then perform the evaluation of the evidence. And then in the lower part, you see all the aspects the panel will address in trying to translate that from evidence to recommendation. And this is, of course, a very rigorous process that has a price. Here you see my secretary. She's usually drowned in all the work because we have been evaluated more than 10,000 studies over the years. And if you translate that for the 2019 guidelines, for instance, all the work together, it's 10 years full-time work of one person. Or you could also translate it in money, 2 million euros in-kind contributions, all completely voluntary. We don't give any payment, so that's fantastic. So these are all the different guidelines we produce because they are all translated. And I didn't have time, but you can go to our website and you can find Chinese, Japanese, Portuguese, and also Portuguese, Brazilian. Carmelita Pedrosa was very much involved in that. Spanish, German, etc. It's Vietnamese, Malaysian recently. So it's fantastic. All these guidelines are translated into local guidelines, local languages. But I would like to end with a call for action, because yes, we have been now translated into more than 25 languages. We, with our team working on this, we cover nearly the whole world. What is actually still lacking a bit is large parts of Africa, but almost everywhere else we have experts involved in our process. But still our evidence, and that's the only evidence we can use, good quality evidence. Most of the good quality clinical trials were performed in high income countries. And to translate the principles, like I said earlier on, for countries like Bangladesh, where a knee-high plaster of Paris is frequently not possible because of the unique context of that country, we do need new studies in those countries. We need more clinical trials performed in low and middle income countries. And I do think that it still is possible, despite the fact that maybe you don't have so much the resources as the high income countries start. For instance, when we performed the Urgo study, which was one of the, I think, largest multi-center clinical studies on diabetic foot ulceration, which laid some groundwork for further studies, and that involved 1,200 studies from centers all over Europe, we set it up with very little money. And we only used very simple clinical measures because we didn't have any money. And still it's one of the most cited studies in diabetic foot ulceration. So yes, I do think that you can perform in the Amazon a clinical study which is relevant for the Amazon, based on the principles we tried to formulate for the guidelines. So please, that's my call for action. Try to develop new evidence so we can better translate what we've been doing also to the low and middle income countries. And for that, I would like to thank you for your attention.
Thank you, Professor Schapper. I think it was a brilliant talk, and I think you gave us a lot of ideas. And I think the last point which you mentioned, that clinical trials are needed from the low and middle income countries, is where Deformities is going to really work on and integrate all the regions and try to get, so that at least in the 2023 guidelines or the 2027 guidelines, we'll have a lot of data from Bangladesh and from other countries. And we will have low middle income countries specific guidelines. So, and this time we have included external experts, and I think you are on the right track to get more of the low middle income countries, people roped into the guidance. And from Deformities, I assure you all the support to the guidance group to implement it in all parts of the world. And we will seek a greater cooperation and collaboration with IWGDF in the months to come. Thank you very much. Are there any questions from the panelists or from the audience? Professor Nair?
Hello, Dr. Vijay.
Yeah, go ahead, Dr. Jamil.
Yes, thank you, Professor Nicholas, for a very interesting talk and for being with us on this special day. My question is the issue that you are evoking about interest in having new studies from middle and low income countries. Will there be any support for studies? For example, if we talk about my country, about Lebanon, this is the first time in our history we are becoming a low-income country. For the first time, we have a disastrous crisis. I hope we will go out and come back to we were the fourth good country in the world. So we have excellent and eminent scientists and medical centers, but we lack funds. Is there any idea how we can get funds to go into a diabetic foot registry or to have to develop studies in the diabetic foot field?
Yeah. Actually, the brief answer is no. This is very difficult. This is what I'm also wrestling in my own countries. Also in my countries, that's why I said shared sense of urgency. Only 1.4% of all the money of diabetes research goes into diabetic foot research. Because, even so in a richer country, people are not interested in this topic. It's low to the ground, it's smelly. And if you ask a surgeon, you can easily solve the problem. Chop it off. So that's one, and that was one of the reasons we set up Eurodal. But I think also Eurodal can help you as an example with very limited funds, with very limited possibilities. You can still do relevant clinical trials. And what I just read, it's in the newspaper. I didn't read the article. Was a recently article in Bangladesh where they vaccinated one area and they didn't vaccinate another area for COVID, and they simply followed it up. And that was a fantastic example from my country where there are still, almost 1 million people who don't believe in vaccination, to show, well, see here, everybody dying in this area and everybody not dying in that area. Extremely relevant study. And of course, I couldn't do that in my country. So I still think that, yes, there are things that are insolvable. Like with the last time we had a very good and inspiring discussion with Deformities, people said to me, what can we do when there is not a vascular surgeon? Because so many of us don't have access to vascular surgeons. And that's, for instance, an area where I can say, I don't have an answer. Because if somebody has an aneurysm in his stomach and blood is going everywhere, you need a surgeon, otherwise the patient dies. If there is no blood going into the foot, you need a surgeon. I don't have another opportunity. But for instance, there are beautiful examples from India of offloading strategies with very simple measures. And we should do more studies like that and try to share that with each other and to implement it also in other countries. And that's where we need meetings like this for.
We have one last, yeah, sorry, go ahead.
Yes, of course, I shut up.
No, we have one last question from Dr. Linda Pedrosa. Nicholas, great review. I wonder what strategies the IWGDF would take in order to make stronger links with the local government. Thank you, Linda, for attending.
A great pleasure.
Well, it's great seeing you, Linda, because you've been so supportive of us from the start. There, I think that's something we wrestle with, and that's why I stressed the enormous amount of work we've been doing, evaluating more than 10,000 articles, 10 years of work, blah blah blah. So also our possibilities are possibility is not the right word, but what we can do has clear limitations. So we formulated that no, we are not there to approach local governments. I simply cannot take that task upon our shoulders. But Linda, because you did that, if you approach me and say, okay, I've organized a meeting and I need your help there with the local government, of course, we will be there, either virtual or in person, or other ways to try to help you. But there we will be supportive, but we will not be proactive. But the hand is out. If you want to take it, it's there.
Okay,
thank you.
Thank you.
Thank you. We have a comment from Simon McConey from Barbados, who says, agreed, a new strategy is needed for health policy implementation by the government. So the same point. So I'd like to thank you, Professor Nicholas Schapper, for taking time off to attend this Deformities program. And thank you for your time, and thank you for your effort in giving this talk to us. And we look forward to a greater collaboration between Deformities International and IWGDF in the months and years to come. Thank you very much.
Thank you very much, Vijay.
Thank you. Yeah, thank you, Nicholas.
We next have a talk by Dr. David Armstrong, who's a professor of surgery and who's a co-director of the USC Limb Preservation Program, director of SALSA and the Keck School of Medicine. And it's a recorded talk because David is not able to join. So I'll just play the video for you.
Ladies and gentlemen, it is such a pleasure to be with you today. And we're going to cover a lot of ground in a very short amount of time. But the goal here is to really figure out how we can maximize ulcer-free days, hospital-free days, and activity-rich days for our patients in diabetic foot remission. And again, we give away all our slides. We just ask you to email us or tweet at us and just make the slides better and pay it forward. That's the big idea. And just to really start the whole discussion, you've heard us make this comparison so many times over so many years, but it's never been more apt than it is today. Like, these complications now are hitting us like a tsunami. We see that foot ulcers in diabetes and complications of diabetes are in many ways equivalent to cancer, certainly in mortality. If we look at all cancers and we look at minor amputations or foot ulcers, major amputations, they're equivalent to a severe form of cancer. They haven't been treated this way in the past, and we haven't talked to our patients this way, but maybe we should. In addition to that, some years ago, we had a technical review where we looked at the best available data, not only about healing these wounds, but about their recurrence. And continuing with that analogy about cancer, when someone is healed here, are they really healed? Because at 1 year, about 40% will get another wound, about 2/3 at 3, and 3/4 at 5. So if recurrence is not only common, and in fact it's likely, then maybe when people are healed, maybe they're not really healed. And if the foot in diabetes is a little bit like a cancer in terms of its cost, its complexity, its morbidity, its mortality, then maybe when they're healed, they're really in remission. And I would just offer this up as another term to use because it really puts things into perspective. And this is true both for the toe and the flow, for the podiatric care, the remission of a wound, and also for vascular remission, because our goal is really ulcer-free days, but it's also ischemia-free days, hospital-free days, and activity-rich days. But let's just talk mostly about the ulcer-free days now, since you've already are going to be hearing a lot about the other technologies. How can we prevent severe recurrence in this population if we can't prevent all recurrence? So in the face of neuropathy, I guess we have an equation that constitutes two variables in addition to neuropathy. They're pressure, and we can modify pressure externally through shoes and insoles, and we can do it internally through surgery or through physical therapy. And we can also modify activity. In the past, we haven't been able to modify activity because it's been hard to measure, but it's gotten so much easier to measure lately. And if you think about it, it's those variables in the face of loss of sensation that's really an imbalance. And our goal is to bring that imbalance of activity and pressure into balance. And we have so many different ways we could do that, with surgery, with medicine, with mechanics, and even with technology. And for so many years, we've talked about dosing activity like we might dose a drug. If you're talking about a drug, too high and you might get toxicity, too low and you might not get the benefit of the drug. For a foot, too high and you might develop a wound. Too low and you might not get the cardiometabolic benefit of activity. But we think we can coax people into being a little bit more active. If you look at this beautiful video from Lieberman's lab in Boston, you see just how elegant the foot is in motion when it's in balance. It's a picture of balance. The trouble is, for many of our patients, that balance becomes unbalanced. And that's when we end up developing complications associated with diabetes. You see here now 15, 17 years ago, we see that we looked at activity and repetitive stress. And what we found was that activity changed dramatically in the people that re-ulcerated compared to the patients that didn't ulcerate. So it was really the irregularity, the variability in that activity that might show up before an ulcer. Someone running to the market and doing 10 things and 2 days of activity in 2 hours. This is what we think we can measure now pretty well with activity monitors. And it's really exciting because we're seeing this now. These activity monitors now have been around for a long time. They're getting amazingly inexpensive. I remember when they were $5,000 to $10,000 each when we had to pay for them for studies. Now they are just in the double digits of dollars. And we see this just continuing to reduce in cost, including in just someone's smartphone now. So it's very, very exciting. We can identify these things and warn patients maybe when they're leaving an activity threshold. And these are things that we're already doing as a team. What's another thing that you might have nearby with your phone and with your camera? Well, we all like to play around and take selfies with the camera, but what about modifying that into the diabetic foot at risk and then to go for a foot selfie? Well, this is something we do on a daily basis. We have our patients send us in foot selfies because they already do this, and we just collate them. This is one of my students, Mark Swardlow. He's a fourth-year medical student, just awesome. He wants to be a plastic surgeon, but you see him here, and every Monday morning at 7 a.m., we go through about 80 or 90 photos or more of patients, and not a week goes by where we don't identify a problem and reduce the risk for hospitalization in that patient. And our patients love it as well. We think now we can add artificial intelligence onto this and really make a clever system. So to be continued. We don't have time to get through all of this, but these are two of my great mentors. It's Paul Brand in the middle, and to his right is Professor Andrew Bolton, and I sort of carry their water for them. I don't carry Professor Brand's water because he passed away about 10 or 15 years ago, but or more now. My God, 2002. But what an intelligent man. He forgot more than many of us know. And what he said back then, and even before that, in treating these patients, is that a wound will heat up before it breaks down. And he was right. We can look for asymmetries in inflammation, and we can measure that. We can do that with thermometry and with thermography. And you see this image from our clinic. But what about this? This is another image from our clinic from just a smartphone attached little thermometer. And we could see a Charcot occurring in this patient who also has a wound beforehand. And we can potentially take action and measure what we're managing and quantify it over time. And these have become very, very inexpensive as well. So again, very exciting techniques and technology that ultimately many of us might be using. You see here, Paul Brand was right. These wounds really do heat up before they break down. And what we are doing now is we tell patients to go onto Amazon and buy themselves a thermometer and then begin dosing their activity by checking their skin temperature, just as they might dose their insulin by checking their glucose. And we have a protocol that we use, and this is something that we think may be useful for the future for many of our patients in terms of very simple, inexpensive technologies that are getting more simple and less expensive as time goes by. We've been working with intelligent textiles for quite some time, and smart socks are one of them. They can measure skin temperature, and in some cases pressure and even joint angle. And we can identify wounds before they break down. There are people that have developed entire companies out of this. This is from a company called Siren, and some of the people that started this company approached us maybe 8 or 9 years ago, saying that maybe they could make a better sock than we were testing in the lab. And, they were right. And they took what we were writing in the 90s about maybe someone subscribing to shoes or socks like they would subscribe to their cell phone bill or their cable or their satellite. And they're doing it. And now they're selling this, and they took this to the Consumer Electronics Show, and they went up against virtual reality and augmented reality. And in this case, reality ended up winning. They ended up winning the grand prize in this TechCrunch hardware battlefield just a few years ago. And now these companies like this are taking off. It's a very exciting time to be working in this field. You see technologies like intelligent insoles that may also show promise, and maybe we can mash these things up into technologies that can communicate with one another. If we can mash companies up that might communicate with one another, I think that could happen as form factors start to be defined. So, Mr. Chair, ladies and gentlemen, it's been such a pleasure to be with you as ever. What I will tell you is that it is such an exciting time now to see these technologies helping us measure what we manage and helping us really achieve a holy trinity of ulcer-free days, hospital-free days, and activity-rich days. Because if you think about it, those are the things that we all want for all of our patients, and hopefully to help keep a few more legs on a few more bodies. Ladies and gentlemen, thank you so much. What a pleasure and privilege to be with you once again.
David, thank you for coming online. I think you're online. So, David, would you like to take any questions?
I'm happy to do.
So, these technologies are very expensive, David. Are these technologies very expensive?
Yeah, I think the answer, Vijay, is that it depends on which technologies. I think all of them are expensive in one way or another when they get started, as many of these are startup companies. However, the concepts are almost free. I'll give you an example. Using a thermometer now costs less. It used to cost, when I was starting in the 1990s, a couple of $1,000s US to buy one. Now they are less than $10 US. So these we ask our patients just to try to purchase, or their families to purchase. In addition to that, the whole idea of a foot selfie and other things like this, where they can send in photographs, that's free. And that's one of the most common things that we have patients enroll in our foot selfie program. And we have foot selfie rounds every Monday morning at 7 a.m. For the week. And, not a week goes by where we don't spot someone and stop a hospitalization. And all of that was done for no cost. So I think we have a mix of things that will be costly. I think some of these implantable sensors will be, but I think others will likely immediately be available, like what I mentioned. Excellent question.
Professor Papinas, any question to David? Professor Papinas from Greece. He's our board member. Any question to David or Harry?
No, that was quite interesting.
I think if I may, David, nice to see you again. I want to ask about, I mean, when you look at the, temperature increase. I remember IWGDF and also, IDF and everyone used to actually supply thermometers to actually the huge ones, to underdeveloped countries and all that to assess the temperature. And then they came out with the thing about diabetic foot syndromes. So do you have a way where we can actually assess all this in a way in lower income countries and also middle income countries?
Well, what I think is ultimately that programs like, I think where in low and middle income countries where maybe a family will at least have, even if they don't have a smartphone, many will, but if they don't have that, they might have a feature phone or a flip phone. You can actually even use a flip phone now to participate in the foot selfie program at our place. And many of our patients that are older do that don't even have a smartphone in the United States. And we do that regularly. And that's been a real success for us. And so this is, and then on top of that, we have people on my team. Mark Swardlow is a young man that's actually leading. He's a medical student now and wants to be a plastic surgeon, but he's kind of leading the charge to try to figure out ways to better register the foot and try to get this scaled up. And I think there are many people around the world that are doing this. Mohun Yap in Manchester is doing this along with other members in the Manchester team at MMI. There are people doing this really all over the world. It's very exciting, including in South Asia and in Southeast Asia. So it's exciting to see this now being pioneered in the developing and the developed world equally well. It's exciting.
David, in the chat box, Simon wants to know about the touch test. Touch test.
Well, the touch, yeah, sure. Well, of course, just checking for neuropathy is free. The old story is that all the tools you need are at hand. In that, I think that was something that when we talk about the Ipswich touch test, I think Jerry Raymond made that joke because you don't need a tuning fork. You don't even need a biothesiometer. You don't need a Semmes-Weinstein, although you can use these and they have varying levels of sensitivity and specificity. But in fact, just using light pressure with your finger, and this is a widely available, there are videos you can watch on our website and others on how to do this. And really all you have to do is touch multiple sites. If the patient can't feel that at one or more sites, then that is actually just about as effective in terms of sensitivity and specificity as a Semmes-Weinstein or a biothesiometer. So I think that's yet another tool that you can use in your clinic, and you can teach other members of your team to do that, be they a physician, a surgeon, a therapist, a nurse, or a technician. So we do that all the time.
David, one last question from Dr. James from Kenya. Is there any app one can load on the smartphone for the same activity?
Yeah. So there have been apps made available for different, I guess, people on the team. There's an app by the Society for Vascular Surgery in the United States that will help someone calculate a Wi-Fi score, although it's super easy to calculate without an app, but it will give a limb threat that's very accurate. But I think the key things that we're going to need to do are to be able to measure tools and have tools that can allow clinicians to measure activity. And this is now, of course, almost free with most new smartphones, even very inexpensive ones. And that tool, I think, when when married with during a physician visit to a diabetes clinic is going to be really revolutionary, I think, worldwide. I've been talking about this for 25 or more years. And before I was talking about it, many people on this Zoom have been talking about it. But of course, Paul Brand talked about it, starting in India and moving to the United States. But I think we need to start dosing our activity, which is free now, by checking ultimately our skin temperature, which is very low cost, just like we dose our insulin by checking our glucose. And on this 100th anniversary of insulin, it's pretty cool now that we on the lower extremity might have something that might help us dose our insulin. And maybe in 100 years, we won't have to be talking about this.
Thank you, David. I think it was a pleasure and it was an honor to have you to give a talk to Deformities community.
Vijay, it's great to see you. And listen, congratulations to the entire Deformities team on this anniversary, on Frederick Banting's birthday, in the evening for you, bright and early in the morning for us. And here's to making a difference, you guys. Not only in India, not only in the KL, but around the world.
Thank you. And thank you, David. And we move on. Simon, your question, we'll take it during the discussion. In the next couple of minutes, I'll give a small presentation on the contribution of the developing world in the field of diabetic foot. So I think we have from the King's College, from my Professor Edmonds and from Ali Foster, this fantastic algorithm for which the developing world can sort of utilize. We have a stage of high-risk feet when all the preventative measures can be taken. And once the foot ulcerates, then it becomes very difficult to treat an infected or necrotic. Then it becomes very difficult in the developing low and middle income countries. And to pick up the high-risk feet, we do not need in secondary care or clinical research, we do not need any big instruments. So all that we need is a proper history taking, a clinical exam, a monofilament exam, vibration, perception, testing, and so on. Next slide. There are some regional differences. This was a study which we published in Diabetic Medicine some years ago among 3 centers, one in Germany, one in Tanzania, Dr. Abbas's group, and our group in Chennai. And we found that peripheral arterial disease is much less common in the developing world compared to the developed world, the Caucasian population. So there are some differences. Next slide. And once again, I would like to focus your attention on the guidelines given by the King's College, Ali Foster and Professor Edmonds, where if you pay attention to all these 6 controls, mechanical control, wound control, microbiological control, vascular control, metabolic and educational control, you can go a long way in saving limbs. So saving limbs, saving lives is the motto of our main sponsor, Urgo Medical. And I think this is what we can achieve in the low and middle income countries. If you pay attention to these 6, and it's not very difficult to achieve these 6 targets. Next slide. Of course, if you have patients like this, we do have cases like this in the developing world. Next slide. Professor Schapper was talking about the total contact cost, which is, we wrote in the guidelines that the non-removable walkers might be better, but even now in the developing world, low and middle income countries, the total contact cost is still a gold standard, and we follow it very much in low and middle income countries. Next slide. If we have somebody like this coming with an ischemic wound, there are facilities in many centers in the world to do angioplasty, peripheral angioplasty, peripheral revascularization of the posterior tibial and the anterior tibial arteries, regain vascularity, and then apply the negative pressure wound therapy and heal the wound. We usually use skin grafting in our countries, low and middle income countries. Next slide. This is another patient who had a necrotic lesion and undergoes a peripheral revascularization. Offloading is very important. Next slide. And you can see the wound has healed well. Last slide. So we showed in this study, which we published in Diabetes Care in 2005, that by proper foot care education, you can actually prevent re-ulceration. You can make the ulcers heal faster. So I think in the low and middle income countries, it's the foot care education which is most important. Last slide. And the IWGDF guidelines has been written up. You heard it from Professor Nicholas Schapper, that it's a good guideline and it's going to be adopted for the developing world also in the years to come. Next slide. We have the IWGDF guidelines on the prevention of foot ulcers too. We next move on to a 5-minute presentation, and after that we'll have another 10 minutes by Urgo, who is one of our sponsors.
Hello everyone, I am Laurent Faugère. I am the CEO of Urgo Medical, and it's a great honor and pleasure to make the introduction of this symposium at Midfoot International. I would like to take the opportunity of this symposium to say a few words about Urgo Medical and to explain you why we have decided to launch such a program. Everything starts with our mission, the mission of the people that work at Urgo and that are passionate about what they do, passionate about the mission that guide us in what we do. What is our mission? Is to heal people, is to help you, healthcare professional, to better manage your patient and to heal your patient. And how we do that? First of all, we do that with innovation. We invest in R&D to have better treatment. And what do we mean by better treatment? Is treatment that will reach your number one objective. And the number one objective of your patient is to reduce healing time, to close wound faster. And this is what we have done through the Explorer study with the recognition that you know in the Lancet, in the NICE, by the international guidelines and many other recognition. We are very proud to have been able to bring a treatment to you. But we know it's not enough. And this is why we have decided to go beyond the product, but to build a more holistic program that is called Closing Wound, Save Fit, Save Life. This program has 3 pillars, and those pillars have been built based on your feedback, on what was needed to improve DFU management. The first pillar is about the organization of care, improving the organization of care. We know it's critical in DFU. We have to have a multidisciplinary approach. We have to know at what time the patient needs to be sent to a specialist or a center, and we are working with you to share the best practice around the world around this organization of care. The second pillar is about standard of care. How can we implement the best protocol based on evidence-based medicine? And the third pillar is about education. Education of healthcare professionals, but also patient education. Education of their families. We know that they are very important to improve prevention, to have a better early identification of the DFU patient. And this is what we have decided to launch an awareness program for those patients to improve their knowledge of the pathology.
Une personne diabétique sur 4 va potentiellement développer un ulcère du pied.
Una lesione del piede diabetico può iniziare con una semplice ferita, una puntura oppure un graffio.
But because of diabetes, that blister, cut or scratch can easily turn into an open wound that can take months or even years to heal.
Años de aislamiento y movimiento restringido cuando apenas puede salir de casa.
Cada día con una úlcera de pie diabético es un riesgo de infección que puede conducir a una amputación y que puede suponer un grave riesgo para la vida.
Alle 20 Sekunden erleidet jemand auf unserem Planeten eine Amputation aufgrund von Diabetes.
COVID-19 pandemic has made the situation worse for diabetic feet.
increasing possible complications.
Ganz wichtig und insbesondere in Zeiten von einer Pandemie ist es, regelmäßig die Eigenvorsorge wahrzunehmen und als Patient idealerweise täglich die Füße zu inspizieren.
Ogni giorno qualche persona affetta da diabete soffre per una nuova voce al piede. Se tu o qualcuno della tua famiglia siete affetti, adesso possiamo agire.
Comment? Voici 4 étapes pour préserver votre pied et prévenir l'apparition d'une plaie de pied.
Step 1, check your blood sugar levels.
Deuxième étape, examinez vos pieds tous les jours.
Take care of your feet.
Fase 4. Indossate calzature adeguate.
Grazie all'educazione e una corretta cura, fino all'85% delle amputazioni degli arti inferiori possono essere evitate e molte vite possono essere salvate.
Check the feet daily and take care for minimal lesions immediately, and do not hesitate to contact your GP if lesion is present and will not heal.
Save feet, save life.
Save feet, save life.
Save feet, save life.
Save feet, save lives.
Dr. Venu Kavartapu is a consultant orthopedic surgeon at the renowned King's College Hospital, London, and he is a current president of the International Association of Diabetic Foot Surgeons, IADFS. And I'm very happy to announce that DFoot International has signed an MOU with IADFS, and we will be starting several joint programs with the help of the IADFS. So on to Venu, and you can take the floor now. You can share your slides.
Thank you very much, Vijay, for that kind introduction. Yes, indeed. The talk given to me is regarding limb preservation in the presence of short-cord foot. So my other commitments include being an associate professor of orthopedics at the University of Southern Denmark. And I'm also part of the education committee of British Orthopedic Foot and Ankle Society. But we are here discussing about the diabetic short-cord foot. Even though short-cord was, the term was described, short-cord foot was described more than 150 years ago. And we know that it comes in so many different forms at different stages, but we still don't know completely the pathophysiological aspects of the development of short-cord foot. But what we know is that short-cord foot leads to reduced mobility in those group of patients. It also reduces quality of life of these patients. It is known to lead to amputations, usually through a series of events, and it also reduces the life expectancy. We know that amputations among people with diabetes carries a very, very high mortality rate, worse than some cancers. But short-cord diagnosis itself is known to reduce the life expectancy. So let's hear a bit more about this short-cord pathology, and who else can be the right person to teach us about how an acute short-cord presentation should be. And Professor Mike Edmonds and his team have taken us through the clinical aspects of an acute short-cord presentation many years ago. It usually presents as a sudden painless, warm, and swollen foot with no real clear history of trauma. And the patient often says that I woke up this morning and cannot get my foot inside my shoe, or I was walking along and I suddenly heard a crack and my foot started to swell up. So often there is no clear history of trauma and the foot becomes very swollen. So when you examine, you can see the swelling, the redness, and this is around the foot and ankle regions, and there is local warmth as well. And it is really useful to quantify that degree of local heat. So a temperature measuring device is very helpful, and it is recognized that if the temperature difference is more than 2 degrees, that is really significant. And either during acute presentation or a bit later, these feet can develop deformity and instability, and that often is associated with marked bone loss that is felt clinically as crepitus, and even in extreme bone loss situations, it can be felt as a back of bones. In the presence of such deformity and instability, ulceration is very common that often gets infected. And you can see this chain of events that is really potential resulting in significant limb loss. So Nina Petrova and Michael Edmonds' team have, in addition to many other clinicians worldwide, have explained to us that the first line of management in an acute Charcot foot presentation is offloading until the Charcot process resolves. And that can take several months. And the gold standard offloading method is a total contact cast. But in some centers, they use, particularly the foot shape is normal, a removable brace, but it's ideal that the brace is kept on all the time. And some centers even have access to more advanced offloading measures, such as a crow walker. Most acute Charcot foot presentations respond very well to these appropriate offloading measures, and the Charcot process resolves, resulting in some degree of foot deformity. But however, if the deformity is severe, if there is associated instability, or if this has progressed to ulceration and infection, the foot becomes at risk of amputation. And in fact, until more recently, the only intervention that was available for such extreme Charcot presentations was an amputation. But however, fortunately, over the past couple of decades, we have seen and learned that many of these deformities can be reconstructible. And as a result, we can save the limb and the patient's life as well. So such functional limb salvage, you're not only saving the limb, but the life of the patient as a result, is required for all forms of Charcot foot presentations. It can be a simple deformed Charcot with completely intact skin. Usually they may not require surgical intervention, but some of them do. Or it can be an ulcerated deformed Charcot foot, or there can be an associated active infection as well. So these, you can see the complexity increases as you go down to the deformity plus infection status. So these more critical limb-threatening conditions should be managed in more a wider multidisciplinary environment. And in fact, all Charcot foot reconstructions do require some degree of multidisciplinary input, but more complex presentations require a true multidisciplinary diabetic foot setup. So we are very fortunate to be part of our King's Diabetic unit, which was set up, the multidisciplinary diabetic foot part was set up by Professor Mike Edmonds about 40 years ago. And the orthopedic component was started in 2006 when I joined. We do infection control procedures, tendon rebalancing, and many other procedures, but the Charcot foot reconstructions remained our primary focus of functional limb salvage. And to date, we have done 176 major Charcot foot reconstructions, and we are pleased to see good outcomes, and we haven't had any amputations following reconstruction as yet. But this has to be delivered in a patient-focused environment with the full multidisciplinary team members contributing to that particular patient's presentation. So let's go through the concept of Charcot foot reconstruction for achieving functional limb salvage. This is a typical midfoot Charcot, and this was treated about 20 years ago. In those days, the standard segmental fixation principle of this deformed and diseased midfoot was applied. Immediate post-operative X-ray looked great, but we know that for a Charcot pathology, that doesn't work. It requires a different approach, a different fixation approach. And it was through our experience during the early stages of our Charcot foot reconstruction program that such failures are due to the application of old-fashioned trauma and degenerated foot correction principles. So through that process, we have learned that the fixation that should be used in short-cut foot reconstructions should include a durable, long segment, rigid internal fixation with optimal bone opposition. And when we applied those principles, subsequently, we have seen very predictable and successful outcomes. So let's go back to a midfoot short-cut presentation example. In this 64-year-old type 2 male patient with a short-cut midfoot and with recurring ulcer, and the foot is deformed due to the midfoot short-cut resulting in excessive plantar pressure or the bone prominence. So the foot shape is also abnormal here. So such short-cut presentations that do not respond to offloading measures that include surgical shoes, then a reconstruction is offered. It's critical that we identify the course of the major vessels in the foot and ankle before, at the time of surgery, before we start the procedure, so that those are clearly protected, because many of these patients come with significant vascular compromise. We excise the ulcers and then redrape and then do the midfoot deformity correction procedure using certain wedge resections based on the surgical planning. And this is what we get. And in this radiographs and the CT imaging, we can clearly see that the foot shape looks normal, the deformity has been corrected, but more importantly, the bone union has been achieved. Means this deformity correction is permanent. And we're beginning to see such type of predictable outcomes. An ulcer due to the presence of deformity starts healing soon after correction of the deformity, and it remains healed. And this patient has remained ulcer-free and infection-free for 4 years. A slightly more complex midfoot deformity with active infection on this occasion, and you can see the amount of bone overlap due to the degree of the bone disruption there. And on this occasion, there is an active osteomyelitis infection as well. So that type of presentations in the presence of active infection require a staged approach. And during the first stage, you remove all the osteomyelitic parts and temporarily stabilize with threaded wires. And here we have used antibiotic loaded calcium preparation, and the choice of that antibiotic was based on our microbiology studies. And with the correction of the deformity and eradication of the infection during the second stage, usually between 8 to 10 weeks, we go ahead with the reconstruction of the midfoot so that the shape correction becomes permanent. And again, the ulcer healing is very predictable as we correct the deformity, and this patient has remained infection-free for 48 months. When it comes to the hindfoot short-cut presentations, in fact, they contribute to most limb loss, and the principle in those is also are also the same. So in this example of hindfoot plus midfoot short-cut, the midfoot had responded to offloading, but the hindfoot deformity remained significant. And you can clearly see that the lateral malleolus is very prominent here due to the presence of the deformity, and you can see the soft tissue shadow around it due to the associated ulcer. So following deformity correction using the same principles I enumerated earlier, again, a long segment rigid fixation with optimal bone opposition using a nail option on this occasion, again, has resulted in very predictable outcomes. So a bit more complex deformity where the short-cut has affected both the hindfoot and the midfoot. And you can clearly see on these radiographs that the ankle and the midfoot are badly affected. And on this occasion, the vascular status is also suboptimal. So that required revascularization before we proceeded with the reconstruction, using the same principles of including the previously affected ulcer in our surgical approach, so that all the previously infected and necrosed parts have been removed, and then access the ankle and subtalar joints, prepare each joint, and do the osteotomies to correct the deformity, starting with the ankle joint. As you can clearly see, reduce that part of the deformity, also reduce the subtalar deformity, and then line them up with a hindfoot nail, nicely compressed so that there is optimal bone opposition, and the residual midfoot deformity can be addressed using a separate incision and fixation principles. So you can see in this plain radiograph that the alignment at the ankle and midfoot are corrected now. So the foot shape looks normal. The patient had lateral radial sections prior to this procedure, but still a plantigrade stable foot allowed the patient commence full weight bearing at 6 months, and the patient has remained ulcer-free since then. So, and then the even greater complexity of infected Charcot presentations. And these are actively infected and deformed Charcot feet, and those require this two-stage concept as I enumerated earlier with one midfoot case example. And this is now becoming the most important functional limb salvage component in our practice. And we have recently published our series of 23 feet in 22 patients, and all of them had achieved functional limb salvage. So an example from this series is this 51-year-old patient, type 1 diabetic, who had pancreas renal transplant, but still developed an acute Charcot that was managed surgically locally, but that got infected, the fixation had failed, and the patient was considered for a below-knee amputation, referred to us for further management. You can clearly see from the radiographs that the midfoot is still very badly deformed, and there are areas of osteomyelitis with very large soft tissue infection, ulceration. So the functional imaging has shown that this has affected the ankle joint as well. So the surgery was done as a two-stage procedure. During the first stage, excise all the osteomyelitic part, large excision or wide excision of the ulcer, remove the metalwork, and take the segment of the midfoot out that has been previously infected. That also helps to achieve deformity correction, temporary stabilization with wires, wound closure, and here we have used the antibiotic-eluting calcium preparation as well that will help achieve infection eradication. So through appropriate medical management, infection eradication was achieved, and at an 8-week mark, the patient was subjected to the second stage, which required correction of the deformity, lining up of the hindfoot under the distal tibia, achieve the fixation of the hindfoot, and then the midfoot through, again, osteotomies and stabilization using beams and locking plates, plus local antibiotic eluting material. That has become the standard fixation for most of these two-stage reconstructions. So the ulcer remained healed, and the bone healing response has been outstanding here. And we have never imagined in the past that such previously infected osteomyelitic Charcot feet could still progress to full bone healing. And the patient commenced full weight bearing at 6 months, and the patient has been ulcer-free for the past 18 months. This patient was the first patient we did as a two-stage procedure in a 60-year-old patient with infected acute Charcot, serious soft tissue infection, and necrosis. At that stage, we opted to manage this as a two-stage procedure, and this was 10 years ago. And following aggressive debridement, wound healing was obtained through negative pressure therapy, and using the same principles enumerated, hindfoot and midfoot reconstruction was done. And the patient came to the clinic on her 10th anniversary following reconstruction, and she was very pleased that she did not opt for the amputation offered from her previous clinical team. So the goal here is to achieve functional limb salvage, and for that we need to avoid a major amputation. So let's quickly go through this reverse engineering process and see how we can avoid a major amputation. When is a major amputation needed? When the foot becomes at risk. The foot becomes at risk if there is severe infection, severe tissue loss, or if there is an associated infection and deformity. So when does the situation arises? Well, if the chronic Charcot has significant deformity and instability component, that can lead to limb at risk. And also sometimes an acute Charcot, despite offloading, can also develop deformity and instability. So all these conditions that make the foot at risk need to be prevented. And that is best achieved by offering reconstruction. If the non-operative measures such as offloading, antibiotics, and other measures fail. So that means an active Charcot with deformity and instability is best reconstructed to prevent a foot at risk situation. And also the most common chronic Charcot with deformity and instability is also best reconstructed. And our understanding on such surgical intervention has become clearer more recently. Now, this is part of this wider work done by Deformity International. It is really inspiring to see so many teams worldwide working hard to prevent unnecessary amputations, and that involves, primary prevention, training on trivial lesion management. But however, all these amputations go through the phase of foot at risk, and quite often, and most often, that requires a surgical intervention. And that is where we, the team from the Association of Diabetic Foot Surgeons, come in. And our team, our board members have released these, opinion documents that were published in different articles. So quite rightly, Deformities International and Association of Diabetic Foot Surgeons have seen this area of our common objectives and goals, and we are extremely pleased that IADFS was able to form a formal collaboration with Deformities International, and I personally am very grateful to Dr. Vijay and Dr. Abbas to make this possible. So together, IADFS will be developing surgical protocols, and then through Deformities International, we'll be sharing our good surgical practice, and we can also contribute to the surgical training and support the Deformities International global outreach programs. And there is also an amazing opportunity to do collaborative research in these areas. So with that, I would like to thank Dr. Vijay, Dr. Abbas, Dr. Jose, and rest of the team members from Deformities International, and on behalf of the IADFS for this opportunity. Thank you.
Thank you, Beno. It was a brilliant talk, and I think we will definitely seek your collaboration with IADFS, FS, and DFOOT, and we will work out a program in the months to come. We are also thinking of collaborating with IWGDF, IDF, with all the organizations. So definitely your organization is on the top of priority list. There's one question from Dr. Srinivas. How do you offload these rigid, if you open the Q&A box, you'll see. How will you offload these rigid fixation patients or something? Yeah.
Yes. So following surgical reconstruction, the rest of the foot remains at risk of developing Charcot reactivation in the rest of the foot, because you subjected the foot to some degree of trauma. And also we need to make sure that the soft tissues and bones heal predictably. So that is best achieved by offloading the leg in a total contact cast. So but the patient will come out of the theater in a back slap, and then we check the wound after day 2 or day 3. If the wound healing is progressing well, the patient goes into a total contact cast, and we wait for a couple more days, change the cast, and if the swelling remains under control, then we discharge the patient in a total contact cast, non-weight bearing. Generally, if it is an isolated hindfoot or isolated midfoot reconstruction, that non-weight bearing duration is for about 3 months. But if it is a joint, combined hindfoot plus midfoot, or a 2-stage reconstruction, it can be up to 6 months.
Venu, you have 2 more questions from India. One
Sure.
is from Dr. Ruke. How do you offload this reconstruct? I think you've already answered that. And then we
Yes.
have a question from Dr. Jain. It is believed that sharp foot surgery on foot is difficult in South Asian population. So what do you have because of osteoporosis?
So it has been believed that Charcot foot reconstruction is actually difficult in all patient population, because all Charcot feet present with, in general, the end-stage Charcot feet present with osteoporosis and many other local factors. I do not believe that it is any significantly different in the South Asian population. So hence the traditional, perhaps the old-fashioned surgical or fixation principles failed in the past, but the modern fixation principles have been shown to be highly successful. Yes, I do not think that the South Asian population have any greater risk of failure.
And Dr. Sangeeta, I think he's already answered. When would you advise an Elizarov technique? I think you've already answered that question. So,
sure. Yes.
So if there are no further questions, I would let Venu go. He had a busy day operating on Shako. He's just back from his theater. He had just time to put on his suit and come for the talk. Thank you, Venu, for, and as I mentioned, Deformities International will work closer with your organization, with IDF, with IWGDF in the months to come. And we have a extremely strong board, and you're going to see them answer some questions in the next 10 minutes. So we have, thank you, Venu. So if you want to take leave, you can take leave.
Thank you very much.
So,
I appreciate it. Thank you.
We'll have the Urgo medical presentation after 10 minutes of this discussion. So we have our strong board, and we have a very tough person, Dr. Douglas Queen, who is going to ask some questions. Dr. Douglas Queen is a global wound care consultant, and he brings over 35 years of international expertise in commercial development, market access, and medtech R&D. And he's done his PhD in biomedical engineering. Dr. Douglas, the floor is yours. Hope your questions are not too tough for my board. We have our board members ready to answer your questions.
Okay, thank you, Dr. Vijay.
Our board, 1 minute. Our board consists of, our board consists of Dr. Abbas from Tanzania, who's the president-elect. We have Dr. Miriam Botros, who's the CEO of Wounds Canada. We have Hermelinda Pedrosa, who is a board member from Brazil. We have Dr. Hari Krishnaya from Malaysia, and we have Nicholas Papinis from Greece. Go on, Douglas.
Okay, thank you again. So good evening to some and good morning to others, especially to David, who was up at the crack of dawn to give his presentation. So my first question, I'll direct these questions to specific members of the board so we get less crosstalk. So my first question, Dr. Vijay, will be addressed to you, and that is Deformities International and other organizations like that are obviously very important to persons suffering from diabetic foot disease. What's the one key message from your conference that you would deliver to a broader audience?
Yeah, so Deformities International, Douglas, is an organization, as you heard from my initial talk, was an organization which partners with IWGDF to implement the guidance which is written by the IWGDF. That is the primary aim with which it was formed in 2017, April 2017, to be precise. Now, what we're trying to do is go beyond that mandate and trying to integrate various regions. We have 7 regions in the world, and we have diabetic foot experts in Middle East. I was listening to Middle East the other day, and we have fantastic work going on in sub-Saharan Africa and Middle East. So I think we need to carry forward the experience of people in the low and middle income countries, and which, as David said in his talk, we had a person working in a leprosy center near Chennai who showed what is diabetic foot all about. So I think our vision in DFoot International is to integrate the various regions across the world, bring the experts from the low middle income countries, and see how they're managing diabetic foot. And of course, the last one is capacity building. We have several programs like the foot trainer program, which has been halted because of the COVID. We're doing online training now. So I think this is the vision of DFoot. We want to integrate all the 7 regions of the world. Thank you.
Thank you very much, Dr. Vijay. Dr. Abbas, as the president-elect, what would be the one key message you would say came from this specific conference?
Yeah, thank you very much, Douglas. As previous speakers did mention, and I will just go over it, developing world consists of 76% of the population, and the rest of the world covers 24%. We have a huge burden in developing world. 80% of diabetes come from developing world. And if you look at only Africa, 46 nations from sub-Saharan Africa, 50% of the population is below poverty, and 95% of population lives in rural area in Africa. 20 countries are the poor of the poorest country. Now, what will be the key message to these people, all this developing world? And this I gave you only for Africa. I would say education, education, education. This is the most powerful tool we have in developing world to avoid diabetic foot complication. It is free to the patient, effective if implemented properly. And that is the reason we are here. If by the time the patient starts from rural area till it comes to the specialist center, it is so difficult to even prevent the death. So one of the main aim of this organization is to implement International Working Group Diabetic Foot Consensus. And this can be done through DFoot International, which is the implementation arm. And this is the education to the healthcare workers. And then the knowledge can pass and cascade to other people. I hope I answered your question.
Yeah.
You did, Dr. Abbas. Thank you very much. As has been said during your conference, diabetic foot is not something at the front of mind of most individuals across the world, but something that has been for the past 2 years is obviously the burning impact of COVID-19. Specifically, how has COVID-19 or the pandemic affected people with diabetic foot disease? And I'll direct that question, I think, to Dr. Botros first.
Thank you, Douglas. Certainly, I can speak to Canada. What we did see within Canada is the reallocation of a lot of services from wound care to focus on COVID-related issues. So a lot of patients and caregivers were really neglected and left behind that were suffering from diabetic foot complications. So that's on one end. We also saw in Canada the uptake of virtual technology. So that was certainly an opportunity that came out loud and clear. Within Canada, we could not determine until now a rise in amputation related to the impact of COVID. I know we saw that in many other geographies, but in Canada, we don't have the data to be able to demonstrate a direct link between COVID and patients with at risk of diabetic foot complications.
Thank you, Miriam. And Dr. Pedrosa, how has it been in Brazil and how has COVID impacted persons with diabetic foot disease there?
Well, thank you very much for the opportunity to give me some opinion about the problem. I think you all know that the COVID in Brazil has been a very big problem, not only for diabetes, but we do still face a very severe situation, although due to the vaccination, at least over 50% of the population is already has already received the 2 doses. But concerning the diabetic foot, unfortunately, I cannot tell you many data about that. But many places have done some efforts to circumvent the situation. But indeed, I understand that it was, and it still has been a very dramatic situation because many of the patients still come with a very advanced and more problematic lesion. So it is still a very big problem. We don't know how we're going to circumvent that because now the system is still getting reorganized in terms of giving focus to the chronic diseases.
Okay, thank you, Dr. Pedrosa.
Thank you.
As we heard from Professor Schapper earlier, other diabetic foot organizations have released international guidelines for the assessment, prevention, and management of diabetic foot disease. But how are these being implemented within your own organization or own geography? And I'll direct that question first to Dr. Papanas. Sorry, I apologize. Papanas.
Sorry. Thank you very much for joining us, and thank you very much for the question. We're proud of having science going on and new guidelines, indeed by the International Working Group and other associations. Now we are beginning to use them more at least in Europe, and that also holds to my country, which is Greece, but I should speak about entire Europe. And indeed, the fact that we cherish these guidelines and this association is reflected, among many other ways, in the fact that every 4 years, the DFSG, of which I have the honor of being chairman currently, the Diabetic Foot Study Group of the EASD, withholds its annual meeting so that people can go, so that we can go to the Diabetic Foot Symposium, the International Diabetic Foot Symposium, to participate and to cherish these guidelines. So we always like them. And there's even new algorithms relating to your previous questions, that is to say diabetic foot and COVID. And some countries, notably UK in collaboration with Los Angeles, US, David was here, and also Italy, Central Northern Italy, have already shown that with telemedicine and restructuring the organization, things can improve. So we're pleased to have these guidelines, and Abbas was saying education, 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 which I'll be happy to remind you is the words of the late Ellie Foster. That's what she used to say. So education, and in this case, education led by, well, VJ's first order of the Jedis of the diabetic foot. So education goes on, and education is aided by all Jedis, smiling or not, and this contributes to what we've been discussing. So again, thank you for your presence and your question.
No problem, and thank you for your answer. So the same question, focusing away from Europe and looking at Asia, Dr. Hari Krishna, how is the implementation of international guidelines in your region?
Thank you, Douglas. I think it's a very important thing that we are actually trying to adapt. I think not only adopt the guidelines, but we have to adapt it. Now, the adaptation is important because the thing is, if you look at, I mean, Malaysia and even Asia, we don't have much of reimbursability like the NHS or even insurance systems like the Medicare, Medicaid and all that. So we have to actually adapt it to our side, where patients actually take out the money from their pockets. So what happens is when we have a guideline, basically it actually goes through the ministry. And what we have done is now we've done a top-down approach. That means the ministry actually adopts these guidelines basically in our clinical practice guidelines, basically, which actually comes out from our medical development division. And at the same time, basically, it is actually brought down to the groups, basically, I mean, from the ministry level, from the hospitals and also the health clinics and so on and so forth. And the most important aspect is what the whole board has mentioned, basically, is about education, education, education. Because if you go back to what they call this Sackett's this thing talking about evidence-based medicine, and then you go down to see actually evidence-based practice. And then recently, basically, I think this year, publications in the BMJ have talked about real-world evidence. Now, all of this basically talk about the evidence itself. And if you look at the IWGDF guidelines, you find that a lot of it is on levels of evidence. And then on top of that, with the grade classification, all this. So with that, we actually need to implement that. And I think it's a big, huge thing talking about standard of care in the world. And if you publish papers, review papers, and like Nicholas actually is also editor of the IJLU and all that, we always talk about this standard of care. So standard of care must be something that is implemented with proper guidelines, basically, and that's how we're actually doing it. So it's important to actually have this kind of thing, and updating is very important. Now, the only problem that I find basically in the lower income group and all that, and also the middle income group, it takes a bit of time. It is not immediately done, and then we have to actually change it to the local language, and also to educate every single healthcare professional to actually start adhering to this. The compliance is also important. So that is one of the things that is actually very important in this region, I would say. Thank you.
Okay, thank you, Doctor. So I have one more question, and I'm going to ask each of the panelists to comment on this. So the situation is you have a magic wand. You're only allowed to use that magic wand once. So please think carefully about your answer. If you had that magic wand, how would you use it to better deal with diabetic foot disease in your geography? What changes would you make? And I'll throw that question to Vijay first.
Douglas, I would use a magic wand to make all the countries in the world members of Deformities International. And I want every country in the world. There are several countries which are still not a part of our organization. So I would use a magic wand to change the articles of association and make it much simpler and include every country as a member country of DFOOT. We have national representatives, we have regional chairs, we have the board, and then we have the General Assembly. Thank you.
Okay, thank you very much. Dr. Abbas?
I'm going a bit practical. My magic one would be control of blood sugar, blood glucose. So once you do that, because this is the root cause of all the complications in patients and diabetes. So we need to aim that. The high blood sugar leads to, it's an important equation, and it also leads to the infection, and that's the way to prevent amputation in diabetic foot. So I would like to want to emphasize this point to both doctors and the patients. Sorry, I gave you one, but I also added the other one. Thank you.
Yeah, you used the magic wand, half here and half there. Same question to Dr. Papanas. I struggle with that name, sorry. So Dr. Papanas, you have the magic wand. Maybe he's having coffee or something. So I'll come back to Dr. Papanas. I'll jump to...
I couldn't hear the last sentence.
Oh, sorry, okay. So you now have the magic wand. So how are you going to use it in your region to improve life for persons with diabetic foot disease?
Okay, well, first I would love to have the magic wand because apart from being a fan of Star Wars, I'm much greater a fan of Harry Potter. And I've once discussed with Professor Edwin Gale, who had a great opening lecture at EASD, which was titled Science of Hogwarts. So although he accused Harry Potter of not being a good example, we had a nice discussion about that. So thank you for this question, and it's a very nice description. Now, all this fervor of mine for Harry Potter notwithstanding, I'm afraid I'm not having the magic wand. Well, you may have read, of course, our special issue in the International Journal of the Lower Extremity Wounds, and the special issue in December. Vijay, you were publishing. I'm not sure about you, Harry. Vijay, you had published, which was Ultrasound, a Magic Wand for Wound Healers. And the title of our editorial was actually A Magic Wand for Wound Healers. So again, all that being said, the magic wand still doesn't exist. But should I have it, I would like to improve, at least in my area, offloading and surgical debridement, not by surgeons, but by GPs, nurses, diabetes educators, and so on, which the default has, as far as I know, run previously before my joining the board. We're in Slovenia and that area educating educators. And so this is to the credit of Deformities International. So I would love to improve that using a scalpel, which is cheap, so not expensive ultrasound, so not the ultrasound of my journal. I would like to use that. And also I would like to encourage better use of loading. I mean, cheaper shoes and elementary use of the better qualities of even street shoes. Now, when it comes to the wider Europe, so not just Southern Europe, not just my country, I'm aware that there are very good companies that produce excellent shoes, and there's an array of scientists which we lack in my country. I mean, rehab specialists, better podiatrists, and so on. And I would like them to also travel around Europe again, like the Educate the Educator, already run by Deformities International. So I would like this expertise to be widely dissipated and propagated also to our areas. So again, it's a very, very, very long answer, but I believe that it's a magic wand. And since I have a magic wand, I can speak as long as I say. Thank you.
Okay, thank you very much. I'm taking the magic wand back.
No. Okay, for a while.
Yeah, so I'm going to pass the magic wand on to Dr. Pedrosa.
Yeah, I think we're very smart to make this question to all of us, because it's a very hard way to answer. But perhaps I would say that I could use the word sustainability. And when I refer to that, I refer to sustainability for education, prevention, and training, because we have been always doing this along all these years, but there is no magic to keep the work be kept, especially in middle and low income countries, where there is more a government policy instead a state health policy. So I consider that the word sustainability towards getting prevention, education, and such training healthcare professionals would be a very good way to get this change in the whole world, especially not today that we are celebrating the World Diabetes Day. And I think diabetic foot is still a very neglected complication. And if we don't get this sustainability towards prevention, we'll never get the very good magic to transform the world.
Okay, thank you, Dr. Pedrosa. So I'm now going to pass the magic wand to Dr. Hari Krishna, if he can give us how he would use the magic wand.
Thank you, Douglas. I think if you see, I'm actually sitting or floating above the globe. So one of my favorite, I think the most important I wish with the magic wand is to prevent diabetic foot complications. And what I can say basically is to save lives and save limbs. So how do we do that? One of the most important thing is empowerment, basically, and also early diagnosis. That is where we are failing now, because that's where they're not coming in. So this is very important. And whatever education you do and all that, they need to detect the danger signs early and come to us, so at least we can intervene fast. So if we do that, we can prevent all forms of complications. And I just want to add, basically, in 1998, David actually published a paper saying that 85% of all diabetic foot complications can be prevented. So why aren't we doing that? So that is the main thing. So I give back the one back to you. Thank you.
Okay, thank you very much. And last but not least, Dr. Botras from Canada.
Hey, now that I'm last, can you give me two magic ones?
You always push the envelope, Miriam. Go for it.
I know. So I think building on all that has been said from our board members, one of the things that I'd love to see in place across the globe is structured diabetic foot health pathways that can move people from prevention all the way to timely management. We really lack this across the globe, the integration and the support for those patients. And if we see that implemented, I think we can reduce a lot of health disparities that we're seeing across the globe, both in the developed and the developing world. And then the other thing that I would like to push for is building on the message that VJ has. We want a lot of D-foot activists to continue to champion this message forward. Thank you.
Okay, thank you.
And,
So
and
now
for everybody who doesn't know, I just wanted to say my claim to fame is Douglas Queen was my previous boss, and he has pushed me in this area and has been the key brain behind Diabetic Foot Canada. So thank you, Douglas, for all your work in this space as well.
You're more than welcome, and thank you for the comment. So this is the close of our session, but I now have the magic wand, so I want to share with you what my use of the magic wand would be. My use of the magic wand would be to get rid of diabetes so that it wasn't a human disease. Because
thank you, Douglas. And on behalf of the board, regional chairs of D-Foot International, I would like to thank you profusely for taking time off to attend this webinar. And we enjoyed every bit of it. And I think you were the right person. When we were thinking of somebody to moderate our session, we couldn't think of anybody else except Dr. Douglas Queen. So thank you so much. And we hope we will utilize your services in the time to come to sort of encourage more people to become members and put an end to diabetic foot in this world. Thank you very much.
You're welcome. Enjoy the rest of your conference.
So what we're going to do in the next 15 minutes, we have 15 minutes before we end. The first is the Urgo medical presentation, which we had stopped halfway through.
Hello, I'm Heidi Corcoran, and I'm a podiatrist working in Hong Kong, and I'm the Vice Chairman of the International Podiatrists Association of Hong Kong, and I'm also the President of the International Federation of Podiatrists. It's been my pleasure to work with Urgo Medical over the past few years. I'm an advisor to the Asia Pacific Advisory Board. I'm working with colleagues in 8 other countries in the Asia Pacific region, and we work together to devise ideas and strategies to help prevent diabetic foot ulceration in our region. In Hong Kong, we've got a population of over 7 million people and an incidence of diabetes mellitus of between 8.5% and 10%. This means that over 700,000 people have diabetes in Hong Kong. Working with Urgo, we devised a website called Save Feet, Save Lives Hong Kong. The website was produced in an English version and a Chinese version in simplified and also traditional Chinese characters. The website was geared towards healthcare professionals on the one hand, so we were able to give healthcare professionals in-depth information about how to diagnose diabetic foot problems, how to treat them, and where they could refer their patients, and how to give their patients advice. On the other hand, our website for the public and for our patients gave very detailed information about how patients could use very simple measures to take care of their feet and look after themselves, and how to spot a problem. And in the event of finding any foot problem, it gave them guidance about how they would be able to find a local person who would be an expert in diabetic foot care in Hong Kong. They would be able to locate services in the public healthcare system, in the local general outpatient clinics, or with a podiatrist or in the private sector. We launched our campaign on World Diabetes Day in 2020, and the launch was not as widespread as we'd hoped because of the pandemic, but we also produced some leaflets also in English and in Chinese to give to our podiatrist colleagues working in the government hospital or in the private sector, and also to distribute to doctors and nurses working throughout Hong Kong. This year, on the World Diabetes Day on the 14th of November, we're planning to continue our launch of our website, and we're planning to promote further. And I've gathered together a team of volunteers who will go out and promote all of the resources that are available to the public and our patients. And we look forward to doing more work in this area in the future. The most important thing is that by helping to inform our colleagues, the patients and the public, is to try to get across the message that if a person with diabetes develops a foot problem and they get an ulceration, they will know where to get the resources to help them. And the really good news is if patients are able to contact an expert in diabetic foot care and work together in a multidisciplinary team to look after them, 85% of amputations are preventable. And it will really help us in Hong Kong to avoid that shocking statistic that every 20 seconds, somewhere in the world, a person with diabetes loses their limb because of a diabetic foot ulceration. So I look forward to continuing to work with Urgo Medical. They've been a massive support to us and really given us the impetus to get this whole project moving. So I encourage you to please join us on World Diabetes Day on the 14th of November. Come and see our website at Save Feet, Save Lives, Hong Kong.
I am Dr. Hari. I am actually the head of the wound care unit, the Department of Internal Medicine in Kuala Lumpur Hospital in Malaysia. Our population has got about 20% the incidence of diabetes mellitus, and there's a huge amount of amputation. One of the behavior models that we should actually cover, or the health models, is to actually start prevention. We actually launched the campaign last year on the 9th of November during the Central Zone Conference. And that was launched by the head of the National Committee on Wound Care from the Ministry of Health. We actually launched the campaign out to nurses, the paramedics, doctors, basically from the private practice and also government hospitals. And this involved the health centers, GPs, and also public hospitals which had got wound care teams. I'm actually involved as one of the representatives for Midfoot, and this was actually launched by Urgo Medical together with Midfoot International. The launch involved the posters, buntings, and panels given out also to the participants who came from the different centers. We have a website for Malaysia itself. So it was translated into a national language to allow not only patients, caregivers, and also the healthcare professionals to visit. WhatsApp is used quite extensively in Malaysia and also in the region. So we actually shot out or blasted out the news about Save Feet, Save Lives campaign to about 146 hospitals and more than 450 GP clinics. I mean, these are healthcare professionals, these are GPs who have decided that, they need to refer early for early intervention, for comprehensive management. So that actually helped. And it was enlightening to see a lot of them actually calling up to have discussions with you. For the next global conference, we want to get the ministry involvement so that the campaign can be launched in every state. We'll be giving out the pamphlets, brochures, we're giving out towels, we're giving out mirrors for food assessments. And also one of the things that we're working with Urgo Medical is coming out with the food assessment kit, whereby we'll be giving out to GPs and health center, medical officers and specialists. So that'll be an early stage so more assessments can be done. Very, very crucial campaign, which has to be supported and has to be rolled out in every region of the world.
We have 10 minutes more and we'll try to do everything possible. And we first launched the info cards. The previous board of Midfoot, consisting of Jose Luis Martinez, Gulapar, and Heidi, and Nina Petrova and myself as president-elect, launched the info cards. And I will now play a small clipping by Jose Luis Martinez before we actually launch the cards.
Hi, everyone. I'm Jose Luis Lázaro Martinez, former president of Deformities International, and I would like to say thank you, especially for the current board, and particularly for his president, Dr. Villay, for giving me this opportunity to share with you the launching of the new info cards on behalf of Deformities International. Unfortunately, I'm not able to be with you now on live because I'm traveling back to Spain from Ecuador because I have to attend for an international diabetic food meeting here in Latin America. But anyway, I think this is another chance, another opportunity to be with you here virtually for introducing the second round of the info card. So let me share my screen and start with this introduction for the second round of the Deformities International info cards. So I think everybody knows the International Working Group Diabetic Food Guideline that has been launching in 2019. In the Netherlands, he's a nice picture with the Professor Nicolas Schapper, who is the current chairman of the International Working Group Diabetic Food, Professor Andrew Boulton, who is the current president of the IDF, International Diabetes Federation, and myself in representation of Deformities International, more or less receiving the compromise for implementation and spreading international recommendation around diabetes foot disease. So I think everybody knows that the current guideline has 7 chapters distributed in some specific topics about prevention, offloading, wound care, peripheral arterial disease, infection, and classification. Probably one of the main problems that we have globally is the gap between the evidence and the daily practice. That is, in other words, the gap between recommendation and implementation. And this is especially the role of Deformities International, because you know that we are the hour of the implementation of the International Working Group Diabetic Food, and is our key role, I think, globally for implementing this international recommendation. Of course, according regional barriers and regional realities, that is not very easy way. So the current guidelines has almost 230 pages. So it's a hard document and a short document, so difficult to read, especially for those who are not a real expert in the disease. And sometimes for some specialties or some healthcare providers that are participating in the management of diabetic food, but not with the with the main action during the daily practice. This is the sample, for instance, for general practitioner or internal medicine, or even some endocrinologists or vascular surgeons. And unfortunately, they are not fully aware about what is the international recommendation. And another important concern is the majority of the patients with diabetic foot, especially patients who developed his first ulcer in his feet, are treated mainly in primary care, especially in Europe and United States. Mainly 70% of patients are treated by their ulcers by primary care. And especially community nurses are not fully aware about what is the international recommendation for diabetic foot disease. So thank you again for the opportunity and for the invitation, and please enjoy this awareness week and increase the awareness around you about diabetic foot. Thank you very much and goodbye.
So we have the launch. The info cards were developed by Jose Luis Martinez, Nina Petrova, Heidi Corcoran, and Gulapar and me, and we launched it. We launched some, and can you just show the remaining ones which we're going to launch? It'll come into our website very soon. And the first one which we're launching today is how to perform a sensory foot examination. So we request all of you to, if you are reproducing it, you reproduce it as it is, because this has been approved by the IWGDF. So we request you not to change the format which has been approved by the IWGDF. Next one. How to ensure the wearing of appropriate footwear. So that's the second DFoot info card which we are launching today. And all these will be in our website, probably translated into some languages. And you can find it in our website very soon. Next slide. How to examine for foot deformities in a person with diabetes is the other info card which we're launching today. And this is quite useful because people who have deformities and neuropathy are more prone to get ulcers and foot infection and amputation. Next slide. The last one is how to select a proper offloading modality. So this is also a very important info card which was developed by the previous board and which we're launching today. We would like to also thank Marta and Matthew's help in the info card, who helped Nina Petrova to develop this. And we got the permission of the IWGDF to sort of have these info cards launched. So they will appear in our website where everybody can access it. And my only plea is, if you're reproducing it, reproduce it as it is, and do not change anything which you see on the info card. Now, before we conclude, we have three more things to do. One, I have asked some 4 regional chairs to talk 2-3 slides on what are the challenges they face in the region. So first we'll start with Simone McConney from Barbados.
Yes, good morning, everyone. Thank you very much for asking me to share. And to me, we're here looking at, we've had a whirlwind of a week and it's been awesome. Global action against preventable amputations worldwide. And for us, it's more like, let's continue this conversation. Can everyone see the slides?
Yeah, we can.
So we had a look at the North American and Caribbean region, and we noticed a couple common denominators. As we looked at Canada, they had a way forward where, you know, their conversation was about the fact that there was a foundation for the need for more education, more research, and more awareness. And this needed to underpin the processes of policy development in all of their provinces. Then we had a spin to the USA, where they realized that they had a tale of 2 counties, where they recognized that in the low income zip code, so depending on where you lived, you may have not got the same kind of foot care. as those in a higher income zip code. And this is a disparity that, as you can see, I caught a wonderful glimpse of David holding his head at the time, because it was a disparity that they had no idea existed and now need to have fixed. And then we come to the Caribbean, and to be honest, a lot of what has been echoed with us as well. And we do not have a robust amount of studies to underpin all of this, but it's pretty obvious based on our Caribbean group that we lack trained podiatrists or foot specialists, and there's a knowledge of lack of knowledge of the pivotal role that we play with limb salvage. We are not just nail cutters. We do heal wounds, we prevent wounds, we debride, we offload feet. And the great thing is for people to understand that we strive for 10 toes and 2 feet. So amputations are really not our first resolve. Unfortunately, in the Caribbean region, most general surgeons see diabetic feet first. They have no foundational underpinning of limb salvage in the way that surgical podiatrists will. And we have a dearth of surgical podiatrists in the region. There's also a lack of interest in the education in general for both general practitioners and some patients alike. So with all the education, all the protocols, all the guidance documents that are out there, the diabetic foot still seems to be a little bit of a secret with regards to its management. And there's also, as a result, there is a lack of timely referrals and limited prevention programs that are there. And to be honest, because we have a dearth of resources in this region, not only in Barbados, but across this region especially, we really need to focus on prevention. So our pathway forward really has to be to create access. And this year, access has really been the underpinning of World Diabetes Day. And the care needs to be first preventative care, secondly appropriate care. And I think the only way we can all achieve it, which is seen both Canadian and the US way, is to build awareness through research to reinforce and strengthen the need for change through education and the support of collaborative efforts within the region to bring a triumphant outcome for all of our diabetics and healthcare professionals alike. Because the reality is a win for them, for our patients is a win for us. So where are we now? Well, to be honest, we have started this process, and so far we have started to build a network of like-minded skill set teams. We no longer try to beat the head against those who should be interested, but those who have joined who are interested, we just pull them in and by natural selection. And we right now have started to build. We have a WhatsApp group that has been going for the Caribbean group. And then we also have started to build relational, we have a better relational process with the Deformities International. So through Deformities International, we formed a Deformities Caribbean WhatsApp group. And then through that, we've now started to build other relations with other regional programs. So Wounds Canada has been very integral. The Canadian Podiatry Medical Association and the Bahamas Diabetic Foot Forum, which they hold a diabetic foot program every 2 months talking about diabetic foot. Because it's important for us to recognize that teams are not really just about the professional teams, but these in our regions where we're so resource strapped, we also need to build capacity to improve training, etc. So more work is needed in these teams. Teams are not, as I said, just the hands-on, but we also need to now agitate a little bit more for government. And we have recognized that research is the underpinning of this, but also the ability to audit and reflect on what has gone on and the pathways forward. We do recognize that there's no need to reinvent the wheel. The protocols and the programs are there, but there's a lot of recognition of communication barriers, and we need to build capacity through these resources and teams. Just recently, I found out that PAHO, through PAHO's World Diabetes message, but Trinidad now has a multidisciplinary center. So now that Barbados has one, Guyana has one, and Trinidad has one, maybe we need to start having a different type of conversation. The reality is that, you know, across the region, the challenges are seen. There are too many silos. They're superheroes. And, you know, I've used the analogy of Incredible Hulk, but the reality is Incredible Hulk did it on his own, but he was a man that went to an ugly giant. And I don't think any of us have the ability to really do this when we're talking about diabetes. And I think what has to be underpinning how we move forward is building capacity through sharing and building of teams on many levels. And on the heels of Remembrance Day, we need to remember that how they fought on the battlefield, and I see diabetic foot as a battlefield, to be very honest. Over the years that I've been involved, it's just been a lot of silos, and we need to really remove those silos and build a family without borders, because nothing really should matter but the skill that you bring to the table. So the way forward for us has got to be authentic and with humility. And whether it is that, you know, we are in the Caribbean, a set of islands, we have sometimes not the ability to have access, so wound dressings and various types of offloading devices and so forth, just like some of our other partners in the MENA region, etc. But does it mean that we have a plane that brings those things to us? Because we don't have the capacity to make our patients go. Whether it be through a helicopter, I don't know, through artificial intelligence. But the reality is that we have to continue to collaborate, build a good working process, supporting each other, building on each other, champion each other. And through building these programs and agitating policymakers, it makes access for diabetes for all and an equitable global service that we all can be integrated within. More like an Avenger, I would say. So with that, we need to be reminded that these are really the true faces of the diabetic foot. This is what we're really doing all of this for. And these are feet that come to us sometimes too late. The reality of the North American and Caribbean region, this is not changing. So we have to change the way in which we work. So let's keep the conversation going, and the time to act has gone. So thank you.
Thank you, Simon. I think with your support and with your campaign, the region will do extremely well in the years to come. I would request Dr. Nalini Campello from the Dominican Republic to be short, if possible.
Okay, hi Vijay, hi everyone. Thank you for this invitation. Let me share the screen. So let's start. We're going to talk a little bit about what is SACA. And as you can see, Latin America and the Caribbean is a geopolitical region that includes more than 40 countries between South America, Central America, and the Spanish-speaking island in the Caribbean. Our predominant languages are Spanish, Portuguese, and we have 400 million people actually living in Latin America. But we have 32 million people they are illiterate. 187 of our people are living in poverty. I understand that the illiteracy, as you can see here, this is the percent of the population that is poor, is very poor and extremely poor. For me, for all of us, the literacy has a profound socioeconomic impact on the rural families, as it perpetuates the cycle of poverty due to limited productive capacity, the lack of skills necessary to obtain formal employment, the inability to educate the children, the insufficient access to basic social services. And with all of this appears the COVID here. So pandemic prompts rise in poverty to levels unprecedented in recent decades and sharply affects the inequality and the employment. As you can see in a new annual report, estimates that the total number of poor people rose to 209 million by the end of the 2020. It means that which is 22 million more people than in the previous year. In addition, diabetes continues to rise. So we are going to have 40 million people with diabetes. But more than 140 million people do not have access to healthcare in Latin America. If we do the math, where are we now? As you can see, if we do the math, that's the way our patients get to our hospitals. The delay in the patient's referral does not occur only by the healthcare professionals. This occurs due to the social reality that our patients, this is the way our patients live. So this, as you can see, this is a real problem, but this is a wonderful team. This team is so positive people that they are facing this reality. They can educate, they can work in their hospitals, but they need to change the policies of their governments to be able to make a true, real implementation of a consensus or a real prevention. In our last meeting that took place in my country, in Dominican Republic, we, all the national representatives of the region, we summarized 3 needs to present to the Deformities, which are the following that you can see in the slide. And I'm just gonna read it as they talk to me to do it, and we decide how to do it. And the first of all is that we need the Deformities to help us to raise a proposal for the World Health Organization to give a code to the diabetic food. Currently, it does not have a code, and the true prevalence of the diabetic food is the pathology is not registered. We need that the Deformities please help us to convince the health managers to invest in the prevention of the diabetic food. And please, we need to provide an accessible tool for data collection. It's so important in our countries because we don't have so much studies in our countries. And I really believe in our people. I think that we can change the world, but first we really need to change our policies. Thank you.
Thank you, Dr. Nalini. I assure you that we will support the SACA region. We have Dr. Linda Pedrosa from the same region in our board, and we will definitely do what best we can for SACA and for every region which needs us. And as Professor Nicholas Schapper said, we need good data from all these LMIC countries. Only then we can pick it up. So next is Dr. Jamil Labi from Middle East.
So I will be brief for the sake of time, and I will deliver to you the 7 wishes of the MENA region. First, what everybody needs is more education. Second, we need more working podiatrists and more offloading tools that should be made available in order to salvage hundreds and thousands of feet. Involve policymakers, because in our region of the world, if we don't have the support of policymakers, we cannot progress forward, even if we have a good strategic plan. And what personally I am trying to do, because I am a lecturer in many universities, is to introduce a special module in nursing curriculum about diabetic foot and wound care. Fourth, establish a diabetic foot registry on a national level. 5, develop wound care societies in our region of the world. 6, start what I call amputation registry, different than diabetic foot registry, with a mandatory reporting, standardized and comprehensive fill form. So every amputation done in any hospital should be reported to the Ministry of Health according to a standardized fill form. Urge, and last but not least, to urge the major industries that are involved in diabetic foot care to reduce their prices and be more available and more accessible to start with in low-income countries than in middle-income countries if the plan works. And thank you very much.
So, Dr. Jamil, if I give you a magic wand, which one you would choose first?
The last
magic
one.
Wand.
The last one.
Okay. So we'll give you a magic wand very soon. Professor Hari Krishnan Iyer, it's not that we have forgotten Europe, Southeast Asia, and other regions. We will definitely, in the next months to come, we will give an opportunity for Southeast Asia, Europe, and other regions to also present. So this is in the brevity, the interest of time, we have asked 4 people. Dr. Nair?
Okay. So I think I'll just touch quickly, basically more pictorial photography of our Western Pacific region. This is the hospital that I'm working at. That's the main disclaimer. And if you look at diabetes, basically it's a global emergency. So what is the main thing from here basically is all 5% of diabetic patients have history of food ulceration. And if you look at the Western Pacific region, we have an increase of 15%, basically in the number of diabetic foot complications. And if I look at this, basically one of you all mentioned with a magic wand, you have to do away with diabetes. Look at the control of HbA1c. Most countries in the whole, region basically is 60% and above, or maybe even 58% above, even the best of countries. And if you have this kind of things, is going to have a big problem. And one of the things, the mission statement of the DFood is to reduce the number of unnecessary lower limb amputations. Also rightly mentioned by Professor Vijay that we have to basically reduce the avoidable amputations, which is a very big important thing. So if you look at the Western Pacific region, we are the largest region in terms of the population numbers. We exceed more than close to 2 billion people in the whole world, basically. And if you look at this, these are the national representatives here. I just put there to show you Shige Kono and Gulappa and myself as the regional chairs. But more importantly is this, the missing countries. But this is just to echo what Professor Vijay wants us to actually bring in more people. So we have now representatives from Cambodia, Laos, Myanmar, and New Zealand will be joining us shortly after the approval by the board and the General Assembly. So we are here to heed the call to actually increase the representation in DFood International, which is the one that Professor Vijay is using. So it's already working. That's what I'll say. And the other thing is, if you look at Cambodia here, you actually have the first diabetes center in Cambodia in 2015, just to show you, even though we are a bit slower, but it is something which is coming up. In China, DFood actually had a meeting with Professor Zhu Zhanrong and group, and it's ongoing basically with the education part. In Mongolia, if you look at that, basically food deformities come to about 16.1%. Infection is at about 26.8%. So a lot of cases are actually coming in, all right? And in Indonesia, the same thing. If you look at the amputation rates in Indonesia, basically, they have a 300 million population. And it can be anything from 20.3% to 35%. And in some cases, basically, even most of the, tertiary hospitals end up with about 41.5% amputation rates. That is what's happening in the Western Pacific region. This is Malaysia, where we actually launched the Save Feet, Save Limbs, Save Feet, Save Lives campaign. It's very important to actually have that. So one of the problems that we have basically is all levels. Basically, we need to have inadequate awareness, like what you have seen in all regions. That means in terms of policymakers, healthcare providers, their patients, public, we need to get all of them into it. That means basically cover services, education, research, supporting systems like how Simone has mentioned about IT, technology, WhatsApp, WeChat. The problem in this region, we have got many, many things. You have got Viber one side in the Philippines, you've got Line, you've got WeChat, you've got WhatsApp. How do we connect all of it? That's another big aspect. And financial support, same as basically in the Saka region and in all other regions, basically that is something very, very important we require because it comes out from their pockets. And inadequate interdisciplinary care, basically, because many diverse specialties. In Malaysia, we don't even have podiatrists in the government sector, basically. So it becomes a big problem. And then there's a variation in the geography and climate, basically, transportation difficulties, and for them to move around is a problem. So one of the 3 priorities, number 1, raise awareness, like what Linda has mentioned about the Saka region. That means basically get the policymakers, get the public level people to come in and make sure that we have proper service, education, and research and development systems, IT and technology supporting systems, and financial support. The other aspect is education, 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 as what the whole board has mentioned. And networking, like what we are doing, like what Prof. Vijay has started basically with the IWGDF and also the International Diabetic Foot Surgeons Association. So with that, expectations of Deformities from the WPR is basically regular activities to raise awareness at global level. So we are actually now networking with the regional groups, basically to actually cover more countries and promote networking between all of them, and organize Diabetic Food Center recognition system. That means we want them to actually basically have proper centers which are recognized as specialist centers and all that, so people can actually go to it. So that's one of the things that we are doing now, basically with the group in WPR, where we will actually give you places where you can actually visit each and every different country, and these people knows, or the patient knows where to go. And the other thing is network sharing centers. These are basically number one, research, number two, data collection, basically registries and all that. And the other thing is data information is very important. So with that, I would like to say that this is one of the things that we are actually launching this year in our conference on wound wars. So may the cure be with you. And I hope basically we will have, we have at least about 42 countries coming in. So I would like to thank you for your kind attention. Thank you.
So thank you, Hari. I think we had 4 brilliant presentations from the NAC region, the SACA region, MENA, and from Western Pacific, the Europe, Sub-Saharan Africa, and SAE, SEA will follow in the months to come. Abbas, Maimuna had asked, requested Maimuna, but she had to go on an emergency call. So it's been a wonderful experience. We had 350 registrations. Finally, 175 people turned up. And even after 2.5 hours, we still have 102 people online. And we finished with the Urgo medical video for 2-3 minutes.
My name is Marco Meloni. I work in Roma at the Diabetic Food Center at the University of Tor Vergata. Italy is one country with the lowest rate of major amputation among the high-income countries. Nonetheless, there are still many barriers in the management of diabetic foot. The main issue is the late referral of a patient with a new foot problem. The second one is the delayed surgical treatment of a patient with critical diabetic foot. According to this daily clinical issue, the scientific community approved and promoted in the last 3 years the DFU campaign with the aim to achieve 3 specific goals. The first one is to increase awareness among healthcare professionals and patients. The second one is to increase education among healthcare professionals and patients again. The third one is to increase the early referral to specialized diabetic foot service of a patient with new foot problem. The campaign has been promoted by national conference, regional meeting and local meetings, involving many healthcare professionals working in the community, such as diabetologists, vascular surgeons, GPs, nurses, and podologists. The main tool used in the community has been the fast track pathway. The fast track pathway is a simple clinical tool addressed to less expert healthcare professionals, in which we have a specific definition of ulcer severity, and according to each grade of severity we have a specific way of treatment and a specific time of referral. The fast track pathway is accompanied by 2 modules approved by DFoot International. The first one is addressed to less expert healthcare professionals, in which we have a global management, a global indication for the management of DFU, including also the signs of alert such as ischemia and infection. The second module is addressed to patients, relatives, and caregivers with a complete description about home medication. The fast track pathway has been implemented in Italy and specifically has been implemented in the last 2 years in Lazio region, and after its implementation we have reported the data about its effectiveness. And among 200 patients we have 25% of patients with late referral, a good result in comparison to the 50% of patients with late referral reported in a recent survey across Europe by International Diabetic Foot Care Group. Not only, but early referral patients reported good outcomes in terms of healing, because among 106 patients, 90% have wound healing after 6 months of observation, and only one patient reported major amputation. We know that we are only At the first step, we need to reinforce awareness, education, and knowledge, not only in our reality, but also in all hidden reality across the country. But we have already good results. This one is only a preliminary data, is only the first step. The second step will be to involve also patients, because patients is the main actor of this very deadly disease, and we have to increase education and awareness about diabetic foot. Thank you very much for your attention.
So Dr. Abbas, who hails from Tanzania and who's a president-elect who will be taking over from me in 2023, I invite you to propose a vote of thanks. Dr. Abbas.
Thank you very much, Vijay. I am honored to do this last task after an excellent meeting we had today. To start with, I would like to thank all the speakers, Professor Nicholas Schapper from Netherlands, Professor David Armstrong from USA, Professor Wenu from London, UK, and Professor Jose Luis from Madrid, Spain, who took the time for the busy schedule and accepted the invitation to talk and lecture on this important issue. Thank you very much indeed. I would also like to thank our moderator, who was excellent of panel discussion by Douglas Quinn. Thank you very much, Douglas. I would like to thank all the board members, role of Deformities International, Vijay Vishwanath, our president, Nicholas, Linda, Harry, and Mariam, and all the regional chairs and counselor of Deformities International for working hard to get this program running smoothly in 7 regions for past 7 to 8 days. Special thanks to our core team of this diabetic foot awareness program, Vijay, Mariam, and myself, secretariat and ID service provided by the personnel in the office of our president, Dr. Vijay from Chennai, India, and especially to Selva Kumar and Ramaya, who were all this what you see were being produced by their hard work. Thank you very much. I should like to thank the sponsors for facilitating this program and making the webinars the reality. Very big thank to all of you, and we would like you to have more cooperation in future. Finally, I should like to thank all the delegates, because without delegates, no webinars are possible. And up till now, we still have 103 delegates attending this meeting. So very big thank you to all of you. Thank you very much. Yes, please.
Yeah, thank you, Abbas. So I think we will organize many such webinars, having seen the success of today's program. And there is a need, there is an enthusiasm to learn from different regions. And our great strength of Deformities International is that we have people from across the globe. And we will continue holding webinars like this. And Abbas and I, this evening, we decided to invite one learned speaker every month. And this journey will continue. And I wish you all the best, and please take care.